Welcome to everybody and those of us joining online as well. My name is Christian Seibert. I'm the board chair of Mental Health First Aid International, and I want to welcome everybody here to this special event jointly hosted with Mental Health Australia. And before I go any further, I want to welcome Uncle Tony, a Wurundjeri elder, who's very generously here to welcome us to his lands. Thank you, Uncle Tony.
Thank you very much for that warm welcome, and thank you all for inviting us here today. I think it's important that we walk this journey together as a multicultural society. I'd like to start the event off with saying Wominjeka Wominjeka to everyone. Wominjeka Wominjeka in the Wurundjeri Wurrung language means welcome. So welcome to Indigenous and non-Indigenous people here today. I'd also just like to say I'm very proud and honoured to be here today representing my people, the Wurundjeri Wurrung people from Corranderk out at Hillsville, where I live today with my family. My great-grandfather was the last Narangeta for Wurundjeri. Narangeta in the Wurundjeri Wurrung language means last head tribesman leading our mob on the mission out at Corranderk, where I live today. He took over from my great-great-uncle. My great-great-uncle was King Barak. King Barak was our fearless leader that took on the government for land rights in the 1800s, right up till 1903 when he passed. My great-grandfather took over Narangeta from there, and his name was Robert Wandin. He led our mob from 1903 right up till 1924, when the mission was closed due to colonisation and being forced out into white society. The Wurundjeri people, they are also a part of the Kulin Nation. So Kulin means man. In the Kulin Nation, we had our 5 language groups. We had the Wadawurrung to the west, the Coorong, who were the westerly neighbours to the Wadawurrung, Tanarong to the northeast, Bunurong to the southwest, and the Wurrung of the Wurundjeri territory that we stand on here today. The Wurundjeri lies of inner cities of Melbourne extend from the mountains of the Great Dividing Range, south of the Burrung to the Mordialloc Creek, west to the Werribee River, and east to Mount Baw. The Wurundjeri people, they have a social totem. It is Bunjil the eagle. Bunjil represented spiritual powers throughout many parts of Australia. Bunjil taught all the laws about life, behaviour and ceremonies, to make sure that our culture would continue for all walks of life throughout Australia. So Bunjil was referred to as the creator of mankind. Bunjil created great people from the land, and that is why we call the land our mother, or the mother of creation. Never can the land be taken away. The land will always belong to Aboriginal people, as we are part of the land and the land is part of us. Our story is similar to yours. Yours is by your chosen faith, ours is by the dream time. We both have creators and beliefs, and ours is Bunjil. It is a traditional custom of the Australian Aboriginal communities to be asked and to give permission for people to enter their lands. And today you've now joined with me to honour the spirits of my ancestors, past, present and emerging, who have nurtured these lands for over 60,000 years. And we, as the owners of the lands, offer a heartily welcome to the lands and hope that together as citizens of this beautiful country, we can build, develop and unite stronger nations for all peoples. I'll close in the Wurrung language, which is Wominjeka, Wominjeka, Wurundjeri, Balak, Yemen, Kumibik, which means you are most welcome to the lands of the Wurundjeri people. Before I jump down and get that loud applause that I am expecting, I just want to touch on a couple of things that I want to touch on the voice last year just briefly to say, we're very disappointed last year that we never got up in October last year. I was on stage everywhere all over Melbourne, a little bit of TV, a little bit of radio, a little bit of everything really, wherever I could get on and promote and to get our people had to have a say in their own country. And obviously when it didn't get up, and I had a really good think about it, I done welcomes probably the next week, and I really struggled with the welcomes, and I'm still struggling today with the outcome of that. I think it's a bit of a total disgrace that the oldest living culture, not just in Australia but in the world, has to ask the youngest living culture of Australia, which is 280 years old, whether we can speak on our own country about our own people. I think it's an absolute disgrace. But I also want to touch on that we do have the treaty coming up. Treaty process is starting to get moving now. From November onwards, it will be really starting to ramp it up. More support from the treaty, the better. We are the only country in the world without a treaty. So it's well and truly time that the government stood up and they asked us to tell the truth. We're here to tell the truth, so where's our treaty? And it's about time they stood up to the plate and actually sat down and had a little bit of a chat to us. But thank you very much for inviting me here today. I don't want to go into that side of things. I'll wait for another day. But thank you very much for inviting me here today. Have a great day, and what a great venue. Thank you.
Thank you, Uncle Tony, for that welcome. And I want to recognise and acknowledge that we are on your lands and the lands of the Wurundjeri people, and I want to really pay my respects to you and the other elders of the Wurundjeri people of the Kulin Nation, and emerging elders as well. And thank you for your permission to come on to these lands of yours that have been your people's lands for tens of thousands of years. And I really want to acknowledge that and thank you for joining us and welcoming us this morning. And I also want to welcome all other First Nations people with us here today in the room and online, and I would like to recognise the work and contribution of our First Nations staff at Mental Health First Aid Australia International, and for the fantastic and important work that they do. I want to thank all of our wonderful staff at MHFAI, led by our CEO, Gus Cleland, there at the front, for putting this event together. My board colleagues that are here as well, and really thank our team for their dedication and their hard work, always furthering our purpose. Really want to say thank you and a real shout out to all of you. And I also want to recognise the lived experience in this room and online, that of consumers and carers, and affirm how it shapes the contributions we make through our work, and in many other ways really important and significant contributions as a result of that lived experience. So as I mentioned earlier, I'm the chair of the board of Mental Health First Aid Australia, and I've had the honour of being on our board for 10 years now and being chair since 2021. And for those of you not familiar with the story of Mental Health First Aid International, it began nearly 25 years ago in Canberra on the unceded lands of the Ngunnawal and Ngambri peoples. And it began with an idea that our two co-founders, Betty Kitchener AM and Professor Tony Jorm, had whilst walking their dog on the streets of our beautiful capital. We have physical first aid, why don't we have mental health first aid? An innovative idea, it's important, but it's only a spark. To translate into real impact, make a tangible difference in the world, an innovative idea needs to be combined with effort, energy, dedication, and collaboration. Through the work of Betty, Tony, many other contributors and partners, a global movement has been built, one that began here in Australia, but now is active in over 30 countries around the world, dedicated to providing evidence-based mental health first aid education for everyone. 1.4 million people here in Australia have been trained by a network of more than 3,000 instructors, and a special welcome to instructors joining us today here and online. Thank you for your work and your contribution. More than 7 million people have been trained around the world in workplaces, universities, schools, and many other community settings. Because our movement seeks to meet people where they are, aiming to give them practical skills and new confidence to have conversations about mental health and mental well-being. Because having a conversation with a co-worker, a friend, a family member, it could change a life, or indeed it could save a life. But the work we do is only one part of a diverse and multifaceted mental health sector here in Australia. All of you in this room and online, the organisations you represent, through your work, through your lived experience, you all play a vital role. Mental Health First Aid Australia International is gearing up to launch our new strategic plan very soon to lead us towards 2030, and it includes a renewed and reaffirmed commitment from us, from the board, all through the organisation, to work in partnership, engaging more closely with like-minded organisations and peak bodies such as Mental Health Australia to advocate for reform and investment in prevention and early intervention in particular. And today's event is a signal of that commitment, and thank you for being with us for it. Just like reform can't be achieved acting alone, a global movement can't be built acting alone, and that's why we're so pleased to have Chuck Ingoglia, Tramaine EL-Amin and Dina Ropke visiting us in Australia this week. Chuck, Tramaine and Dina are the President, Vice President and Chief Program Officer, respectively, of our largest international partner, the Council for Wellbeing in the United States. Since 2008, thanks to the National Council's efforts, more than 3.8 million people in the US have been trained in mental health first aid. A really remarkable achievement that I really want to congratulate you on and express, appreciation of that work. One of those people was actually the former First Lady, Michelle Obama, who did the training back in 2015, commenting about how useful and practical she found it. And this underscores the influence and the reach of the National Council as the main mental health peak body in the US. As part of its work driving policy and social change on behalf of more than 3,400 mental health organisations, they've had significant wins when it comes to achieving policy reform in a range of areas. Though, as we know well here in Australia, that work is never really done. It's always ongoing. Chuck's been at the centre of this work, having joined the National Council in 2005, spending the next 14 years leading its public policy and practice improvement efforts before becoming President and CEO in 2019. A very opportune time to become President and CEO, given what happened not long after. I'm really honoured to welcome Chuck to speak about his experiences and what we may be able to learn from them here. His address will then be followed by a panel discussion moderated by Carolyn from Mental Health Australia, our co-host today. Now, one last thing, if you notice that Chuck is glowing with a bit of more positive energy than normal, it's because yesterday I hear that he, Tramaine and Dina got to hang out with some koalas at Healesville Sanctuary. Not the koala we've got out the front, but some real koalas. Now, unfortunately, those koalas have to stay at the sanctuary, though I would like to rename one of them as Algae. But I'm pleased that we'll be able to send Chuck, Tramaine and Dina home with a few little algae soft toys to join the Mental Health First Aid US algae koalas that you've got over there as well. So thank you, Chuck, and looking forward to your presentation.
Well, what a pleasure to be here my first time in Australia, and I don't have too bad of jet lag, so it's a pleasure to be here. Now, I do begin this conversation with some trepidation because the US healthcare system is not one that would frequently be replicated. So I want to acknowledge that and talk a little bit about the journey that our organization has been on for the last 17 years to try to effect systematic reform of community mental health in the United States. And this might be odd because we're an NGO engaged in this work. And subsequently, the federal government has gotten interested and supportive, but it's probably maybe different than your model, where it was not led by any kind of federal commission or initiative, but really a grounds-up approach from an organization like ours. And I would imagine that the issues that you confront in your mental health system may be similar to some of the problems that we have been trying to solve in this current reform initiative. That there are certainly pockets of innovation across the country, but they're not consistent. Where you go for care, we have 50 states. If you show up in a southern state, the experience you'll have there is very different than, say, another state. Now, that is not true for physical health conditions. If you have a heart attack, no matter where you show up in an emergency room in the United States, you will receive comparable care. Why can't people with mental health and substance use conditions be guaranteed the same? Why should it matter where you happen to live? So that is certainly something that we're trying to address, as well as some of these other issues of inconsistency, inability to hire and retain workforce, persistent levels of unmet need, and certainly our community partners desperate for more access to mental health services. If you think about the first reform that happened in the United States in the 1800s, it was to get people with mental illness out of jails, and that time into asylums where they could be treated more humanely. And here we are several hundred years later, where it is now the majority of people with mental illness receive treatment in jails and prisons. And we have an opportunity, an obligation, an urgent need to change that situation. And that is what we're trying to do. And here in this 20 minutes, I'm going to try to summarize 17 years of work that we've been up to. So I'm obviously not going to be able to talk about everything, but I'll try to hit the high points. And certainly, an interesting policy framework in the United States is this notion that within the different ways that healthcare is funded, mental health and substance use should be treated comparably to physical health conditions. That has not always been the case, that insurance companies have been able to provide fewer services, reimburse less, and treat mental health and substance use conditions inconsistently. And there's been a huge push in private health insurance for comparability. And unfortunately, in our country, most people, especially with more serious mental illnesses, rely on public programs for reimbursement, for access to care. And we took this parity concept and tried to apply it to that sector as well. So we have, since the 1965 in our country, a network of primary care clinics known as federally qualified health centers. And in recognition for their service to low-income individuals, they have a variety of federal policy preferences to try to enable them to complete their mission. And in fact, most low-income people in this country receive their primary care through an FQHC, a federally qualified health center. And so what we did is we said, why, if this is working on the primary care side, why don't we have something comparable for mental health and substance use? And that's where this notion, what we first called federally qualified behavioral health centers, but that association that represents federally qualified health centers didn't like that. So we call it now certified community behavioral health clinics. Always some politics involved in how these things evolved. That's where this notion evolved. And the idea would be that the federal government would establish minimum standards and then incentivize states to participate, to expand not just the types of care that's involved, but also the way that care is coordinated and shared. And so these clinics are required to do a number of things, to have lived experience councils, to have relationships with hospitals and jails and prisons, to make sure that they have relationships with homeless shelters and other social service providers. The notion that these are where people with mental illness and substance use might be encountered, and you want to make sure that they have a consistent experience of care. Also pretty radical in our country was the idea that these clinics have to provide both mental health and substance use services. And this has not been common in our country, that you could get consistent care for both a mental health and a substance use condition in one place. And we know, I think, from our experience, right, that many people have multiple health conditions, multiple mental health and substance use disorders, as well as the need for primary care. In fact, in the United States, it's well established that people with mental illness and substance use disorders die at the average age of 52 because they don't have access to primary care. And so the other requirement is that these clinics must screen for and arrange and or provide primary care services. So this is the idea. And I think probably the most radical part of this is that the way the funding situation is set up historically, mental health and substance use services, or the payment rate that clinics received, is based on how much money is available, not what is actually required to deliver the service. And actually that was one of the other kind of foundational principles of this model, was that the clinical design should drive the financing, not the other way around. The financing should not determine what is done clinically, but the other way. And we had done some work about 19 years ago for SAMHSA, and SAMHSA, the Substance Abuse and Mental Health Services Administration, which is the federal agency responsible. We'll use that term loosely because nobody's responsible for healthcare in the United States, but concerned with mental health and substance use. We're very confused why evidence-based practices weren't being conducted more consistently. And we spent some time looking at the different financing mechanisms, and we came to a very simple conclusion. None of the available financing mechanisms actually reimburse for the full range of requirements that most evidence-based practices require. And so the funding model here is called a prospective payment system, where you look at what are all of the requirements, how much does that cost to provide, you estimate what you think it will cost, and then you look at how many people you serve, you take your costs, divide it by how many people you serve, and that becomes a rate that you're provided for services. It's very simple. My children take calculus and all these things, so this is like basic arithmetic, numerators and denominators, even I can understand it. And that's how the payment rate is established. And what we've seen is that these clinics have had the opportunity to really expand their workforce, because one of the, when you don't get paid adequately, one of the problems that you have is that you can't pay competitive salaries, and it's very hard for people to want to come to work for you. And so we've seen huge expansions in certain areas of physicians and other prescribers being employed, peer support specialists, and substance use counselors. That's probably those are probably the three areas with the highest growth. But then other things like data analysts, people focused on quality improvement, things that ordinarily you wouldn't have the funding to provide. So those kinds of things. With a huge emphasis on services being provided outside of the four walls of the clinic, in community where people are. And certainly the feedback we get from staff is that they feel much more empowered. They're operating in clinical teams, really focused on the needs of individuals as opposed to focusing on revenue generation, that they don't have that kind of pressure. And in our system, what's really mattered is that policymakers have been very supportive of this. I mentioned earlier that we based this model on federally qualified health centers, and our legislative champions happen to also be the legislative champions of federally qualified health centers. They adopted and promoted this work and really shepherded it. And both of them, Senator Debbie Stabenow of the great state of Michigan, where I happen to be from, her father had mental illness, and she experienced firsthand the consequences of inadequate access to care and has really promoted this idea. But I cannot underestimate the importance of having consistent, powerful legislative champions to make this work. I think the other than growth over time is that people have experienced they've had a different experience of care and have been able to talk about that. And then that has led to a lot of local support. In our systems, the way that our payment system works is if somebody is a resident of a psychiatric hospital and an outpatient clinic wants to go and establish contact with them for continuity of care, they could do that, but because that person is a resident of a hospital, they cannot get reimbursed for it. So a clinic, under our current historic ways, was disincentivized from making contact and promoting continuity of care. Under this model, even though you won't get reimbursed for that person going, the cost of that person can get built into your funding mechanism, and you can go do that. Or you could have a person hanging out in an emergency room who's doing screening and maybe suggesting that people should not be admitted to a hospital but receive care in the community, or a homeless shelter, or schools, other places where people might be experiencing care. These might sound very you might be wondering, why is this even a thing? But this is like revolutionary in our country, that you would actually have the flexibility and the consistency in funding to do that kind of intervention. And so we've had significant investment by Congress, which is then leading to growth in this model over time. So we started with an 8-state, 2-year demonstration. I assure you this was not developed in some policy think tank. The day before our legislation was going to get voted on, we were told, you can spend $1.1 billion. How do you want to spend it? And that's when we came up with this 8-state, 2-year demonstration. We then had expansion to 10 states during COVID. And then just in 2022, another investment of over $8 billion that over the next 10 years, every state will be allowed to participate and to bring this model to their community. I would say the other thing I would just want to mention here, just in 2024, I actually should update this slide. We actually got the CCBHC, the Certified Community Behavioral Health Clinic model, listed as a service in our federal Medicaid statute. So for the first time, this is the first time in our federal law that we have ever had a designated benefit for people with mental illness and substance use conditions. So that was kind of mind-boggling that we were able to accomplish that. And it has our federal policymakers really a little befuddled, especially the people who operate the federal Medicaid program, because for the first time, things like supported employment, supported education, will be able to be funded at the federal level consistently through Medicaid. We have never had that before. It's been, actually most states have been unable to use federal Medicaid funding for those services. So that is something that we're very excited about. Now, we've had tremendous growth. I think we now have CCBHCs in 60% of US counties, overrepresented in urban places, but not exclusively. And so we do have a commitment to work with more rural and frontier parts of the country to make sure that they have access there. And unfortunately, this is not something particular to this model. It's kind of the nature of our country that less populated places have a hard time in general financing care. I guess I would just want to say that, this has been a dream of a lifetime, and I think our organization has at its core a set of values, and one of our values is to shape the future. And it's amazing when you embrace your values that you can actually accomplish incredible things. I would have never imagined that we would have been able to do this. And I try to say to my staff, it is not every day that you have the opportunity to re-envision how mental health and substance use care is organized and financed in a country as large as the United States of America, as complex, as dysfunctional, as lots of things. And it's a tremendous opportunity, certainly feel a lot of pressure, and I hope that there are elements of this that will resonate. And I do feel some trepidation in this audience because Australia is such a leader in mental health care. So many incredible programs and ideas have originated from here and been spread all over the world. Hopefully this will provide some context for kind of the journey that we have been on. And even though it's been a 17-year journey, we're not done. I know that we'll have many, many years of trying to bring it to scale. We have a number of states, I think we're up to 20 states now that have CCBHCs, but not everywhere in their states. So we're working with states to really bring the model to scale, and then working with, over the next 10 years, to bring it to every state. But we've only really had two other movements in the United States of this scale. The first was Dorothea Dix and her whole movement to create psychiatric hospitals or asylums. Then in 1963, when President Kennedy signed the Community Mental Health Center Act, which was the first federal initiative around mental health. That act only stayed in federal law until 1981. So this is our third try at systematic reform. I'm hoping it'll last a little bit longer than last time. And I'm confident, actually, that because of the results that we've received, that will continue to grow. I'm happy later, afterwards, to take any questions that you might have, to learn from you. And I thank you for this opportunity to be here in your wonderful country. Thank you. Why is this? There we go.
Thank you, Chuck, for those reflections and some really interesting experiences. Obviously, lots of differences between the US and Australia, but some similarities as well in terms of our federated nature of our countries. So lots of food for thought there. I now want to welcome Carolyn and our wonderful panellists for our panel discussion. And as you'll see on your tables there, you can ask questions using Slido. There's a QR code there to facilitate the discussion. So yeah, thank you, Carolyn.
Great, thank you so much. And I will welcome our panellists to join me on the stage when you're all ready. For those of you who I may not have yet met, I'm Carolyn Nikoloski. I'm the CEO of Mental Health Australia, and I'm thrilled to be here today partnering with Mental Health First Aid International to co-host this event. I would like to thank Uncle Tony for his very warm welcome to Wurundjeri country, and I would like to also acknowledge the Wurundjeri people as the traditional owners of the lands on which we're meeting today, and I pay my respect to their elders past and present, and also acknowledge any Aboriginal and Torres Strait Islander people joining us in person and online today. I would also like to acknowledge those people with lived experience of mental ill health and suicidality, and along with those who love and care for them, and your really critical role in driving reform in our mental health and suicide prevention systems. So thank you again to Mental Health First Aid International for partnering with Mental Health Australia to host this event. I would also like to thank and welcome our other speakers who are joining us today, Tramaine, Ingrid, Karen and Rahul, and we'll hear from them in a moment. But I would also like to thank our keynote speaker, Chuck. It was wonderful to hear some of the similarities across our mental health systems, but also some of the opportunities to think about how can we work differently to really embed new service models across our mental health system. And I like that sense of resilience you showed in terms of just keep trying, acknowledging that this is really hard to achieve change. But it's wonderful to see how you have developed and then scaled up the service model across the US. And I loved your line about, you can use your values to shape the future. And I think we can all take that mindset into how we approach changing and improving mental health in Australia. So thank you so much for sharing your insights with us today. So before we move to the panel discussion, I thought I'd just take a brief moment to introduce you to the work of Mental Health Australia, along with some reflections on some of the recent progress we've had in mental health reform in Australia. So for those of you who aren't familiar with our work, Mental Health Australia is the national peak body for the mental health sector. We have over 140 member organisations reflecting the diversity and breadth of the mental health sector, including service providers, researchers, lived experience advocacy bodies, along with workforce representative associations. Earlier this month, I was really proud to launch our new 5-year strategy, which sets out 2 key goals for our work over the coming years. These include, firstly, driving better mental health policies and systems, and secondly, uniting and strengthening the sector. Over the next 5 years, we'll have a strong focus on partnering with both our members and governments and people with lived experience and their family carers and supporters to develop and advocate for practical policy solutions that will both deliver improvements in the community's mental health along with enabling the sector to thrive. We'll also continue with our critical role of bringing the sector together to learn from one another and share insights, as we're doing today, along with ensuring that we're speaking with a united voice and ensuring that we, the sector, can take a lead role in delivering change in our communities across the mental health system, rather than waiting for governments to lead the way. So last week, we saw the first National Health and Mental Health Ministers meeting in years. And this was a really crucial opportunity, in particular ahead of upcoming state and federal elections, for health and mental health ministers to come together and agree on bold reform that will make real change for people needing mental health support in Australia. Mental Health Australia led the development of a statement of priorities that was endorsed by 80 of our member organisations. In that statement, we set out 3 immediate steps for governments to take to progress the reform agenda. These included, firstly, agreeing to the public release of the National Analysis of Unmet Need for Psychosocial Support outside the NDIS, which pleasingly they did immediately after the meeting. Secondly, to commit to ongoing twice-yearly mental health minister meetings to progress reform, which they also committed to in the meeting, with the next meeting having a particular focus on child and youth mental health, along with how we can address unmet need. And finally, we asked governments to commit to a national accord to co-fund a system of supports bridging primary and acute care. That third recommendation hasn't yet been adopted by government, but we now have a path forward for continued intergovernmental negotiations and discussions and an agreement to work together with the sector along with people with lived experience and their family and carers, to develop a robust plan for psychosocial support arrangements. Of course, we still need firm funding commitments for action to happen, and we need that from all levels of government so that we can respond to the unmet need in community. But I think it's fair to say that changing mental health policy, it's a long, hard slog, and it's important that we stop and reflect along the way. And last week's meeting, it was a step forward. It showed that governments are listening to the community and to the sector, and it also shows a willingness for governments to work together to achieve change. So that's progress. And these are really critical components for us to fundamentally change the trajectory of mental health in Australia. The challenge governments are facing in responding to the mental health need in Australia is huge. But I'd say that the passion and expertise in the mental health sector and within lived experience advocates is equal to that challenge. So with that sense of hope, we're now going to move to our panel discussion. So in today's panel, we'll hear from experts in the sector to discuss future directions for our state and national mental health centre programs, understand how some of the lessons learnt from the US can be applied locally, and explore potential solutions to advance our mental health reform efforts. But first of all, I'd like to invite each of our panellists to introduce themselves briefly and explain their role and a bit about their perspective on mental health reform. Ingrid, I might start with you.
Thank you, and thank you very much for the invitation to be here with you today. I come from a space of personal experience, and I'm one of the lucky few Australians who's actually had really quality care mental health support and services that have, over the lifetime that I've experienced these since I was young, has actually helped enormously with my recovery and my healing. That's not to say that I don't still face challenges. However, it's because of that quality wraparound service that I've had that I'm actually able to contribute to be here today and in the work that I've been doing over the last couple of decades. And I'm informed in everything that I do, whether it be research, education, whether it be policy reform. It's listening to other voices and listening to community around what works and doesn't work that informs me and my passion, in fact my crusade, to want to use my voice today as a consumer and as a carer to make a difference to our way of being and doing for whatever human condition we may experience at any time in our lives. Thank you.
Thank you so much, Ingrid. And Rahul, we'll go to you next.
Thanks. Good to be here. I'm Rahul. I co-lead Transforming Trauma Victoria alongside Lived Experience co-director Charles Chu. We're essentially the new name for the statewide trauma service, which is being established and co-designed at present, and emerged out of the Royal Commission into Victoria's mental health system, attempting to really kind of address trauma at scale across the community, which has been kind of so pervasive yet hidden for so long. So we've certainly been very glad to see that problem kind of addressed and recognised, and also for the reform of giving us the opportunity to take a step back, reflect, collaborate, and try and think differently about how we set up and set up a new system really from scratch. And I think reflecting on Chuck's comments, it's really driven home for me the patience and persistent kind of will and collaboration that's required to really have that change over time. It won't happen in a single electoral cycle. We just have to kind of keep the foot on the pedal. So thanks.
Great, thank you so much. And Tramaine.
Good morning, afternoon, not sure. Great to see you all and so grateful to be here. My name is Tramaine EL-Amin, and I have the pleasure of having one of the best jobs in the world, I always say, which is going around the country in the US and telling people what to do, which is to care about each other, to care about the work that they do in workplaces, and to care about mental health. And so one of the ways I get to do that is as the Vice President for Mental Health First Aid USA. and growing and helping to grow that program alongside just amazing human beings who get to kind of inform how we look at our community mental health through the lens of early prevention and early intervention, as well as from a reform perspective, just having the experience of implementing at a city level mental health legislation, especially in light of the Affordable Care Act legislation that happened in the U.S. About quite a few years ago. And so from that experience to this national experience, it's just been a pleasure to see what it looks like for an ecosystem of different organizations to come together and really push forward not only legislation and change, but also how are we making that community impact through the work that we do? How are we connecting the dots between our systems of schools, providers of public safety, those that are in areas where English might not be the language that they're using. How do we make sure we're translating those efforts? And so really excited about the work that we get to do together and excited about the conversation today. Thank you.
Great, thank you so much. And Karen.
Thanks, Carolyn. I'm Karen Thomas. Welcome. I feel like I'm in a room of my tribe or kin. I really like being here and want to welcome you and Chuck to the temporary Australian tribe. So I am the Director of Community Connection and Wellbeing for NEMI National. NEMI National, some people will know, is a specialist mental health provider, an NGO, community managed organisation that has services, diverse services across the whole of Australia. So I am lucky to look after all of our psychosocial programs across Australia, and I'm absolutely in love with my new title because I think it speaks to what my values are and where they lay around community and connection and wellbeing. The reform question is an interesting one. I have worked in the sector for quite some time, and I'm sure many of you have. And the amount of reforms and initiative I've seen is ridiculous because you don't get time to do that embedding and establishing and then developing and improving bit, because we're on to the next thing and we're on to the next thing, we're on to the next thing. It impacts on staffing, it impacts on consumers, it impacts on the whole sector. So, I just kind of want them to slow down a bit and just stick with one initiative for a while so that we can focus and get that really, really good for people. Yeah. So,
Thank you. I think that is such an important point in terms of there is such an urgency for change, but it's important to balance that with the reality of how to implement new programs and services well and embed them, and taking the time to learn on what's working and what's not working and how we can embed a continuous improvement mindset across our work. So I think they're really important comments. Now, I have a few pre-prepared questions for our panellists, but just a reminder, if you're not yet on Slido and if you've got some questions for our panellists, please feel free to pop them in and we'll come to those shortly. But to kick us off, Tramaine, I might start with you. And thinking about what the CCBCHs, I hope I've got that acronym right, look like in action, can you provide us with some examples of the partnerships between different agencies, such as peer workers, law enforcement and local government, and how those have been implemented to ensure a really coordinated approach to mental health support?
Absolutely. At the core of what a CCBHC is intended to do is to create that network of support, not only for that organization that's providing the care, but also to the community at large. And I think that one of the ways that we've seen, is particularly with peers, a number of organizations have implemented and had the opportunity to expand their workforce. So I don't know about you all, but when you walked in the door, you didn't leave like the parts of yourself outside the door. You came in with your whole self. And a lot of our organizations, people who might have mental health challenges in addition to substance use challenges, are coming in to get care for both of those things. They might also have co-occurring physical health challenges. And so a lot of times peer support specialist programs are either one or the other. And what CCBHC funding and the funding mechanisms that exist allow folks to do, and we've seen that happen, especially in New Hampshire is a place we've seen it happen. That funding has expanded the peer workforce such that folks can have specialization in supporting substance use, mental health and co-occurring challenges. In addition, you mentioned 2 other areas, one of which was law enforcement. And so for many years, there's been this collaboration within community mental health to really try to divert folks from having to utilize law enforcement services or jail diversion programs. And so what CCBHCs allow, that again, that funding mechanism allows to happen, is that individuals are being partnered with, whether that's a social worker or another community health worker, doing work like ride-alongs with individuals that are in the law enforcement, or being a resource to law enforcement. We've seen that really in states like Texas and states like Maryland, places where there's opportunity to really enhance the connection and collaboration among law enforcement and the mental health providers. They are all working toward that same aim, but there's an opportunity now to have that aim funded and supported as opposed to just another thing that needs to be done.
That's great. It's great to hear that that's part of the service model as opposed to an optional extra that is often not funded but expected and known to be good practice. We might now turn to kind of the Australian experience. And Karen, I'm keen to hear from you in terms of what the implementation has been like at NEMO with your walk-in centres and what some of your lessons learned have been.
Okay, sure. So I was lucky to be work with a great group of people around establishing 2 of our centres. We have a few of them, one in Townsville in Queensland and one in Darwin in the Northern Territory. They were pilots or considered pilots at the time, and so it was all new and pretty exciting. And it was a big mission. So NEMO are really conscious that this is an opportunity to do things different. If we continue to deliver the same, we're just going to get the same results. Nothing's going to change. So we really, really thought about what model do we want to implement when we do these centres. So a couple of things are really fundamental. We have a 50-50 clinical peer workforce. We also have a peer first, peer last model, so that a person walking through the door is working with a peer the whole way through their journey, so they're supported through that. It was interesting. One, we had the normal challenges, and I think Chuck talked about this in America as well with recruitment. And recruiting to roles that were new, we were looking at a transdisciplinary approach. So rather than, multidisciplinary, we were really looking at the transdisciplinary and what did it actually mean and how do we mix those together to make them work better for the consumer walking through the door. And so recruiting into those roles was one of the challenges because people they're still fairly new in Australia. There's still more of the multidisciplinary really. And so what does that mean for me? Like, what's my scope of practice? How do I work in this space if it's going to be transdisciplinary? So they were some of the initial challenges, absolutely, and things that we are still working on and work to improve and get better at all the time. So that was some of the challenges. Some of the amazing things with this is that we were funded to do really deep, co-design. And normally with funding, you don't get that opportunity. They don't give you the funding to do that. But they did with these because they were pilots. So it meant we could work really closely with those communities around what did they need? What was the actual need and how could we meet that need? So they're very contextualised to the community. So they're not cookie cutter. If you walk into one place and they're not going to look the same. But, as Chuck said also, the service should be the same. The service that people can access when they walk through the door is the same. But they look very different. If anyone's been in any of NEMO's centres, they all look very different because they're contextualised to that. So, and it was hard because it's a pilot and it's so new. It was all about learning, continually learning. Stuff around safety, for example, in those centres and operating those centres so that the people walking through the door were safe and that the staff were safe. And so there was some great learning in that for us and what we needed to implement in those spaces as well. And the community engagement, I think we're kind of at a stage now though, we've been operating them for 2 or 3 years now, that we'd be excited about going back into another co-design process to look at pathways in the ecosystem now, I think, and what's changed and what needs to be different now moving forward.
That's great. Thank you so much. And Ingrid, I'm keen to hear from you in terms of what do you think might be needed to ensure that more people can get access in mental health walk-in centres?
We don't know what we don't know. And when we're in a crisis or we're in distress, at those moments, not always are we informed to know, actually, where do I go to? Or am I even capable of thinking of where do I go to? And then there's expectations that someone else around you will know what to do or where to go to. When we have a disaster in this country, we are amazing in our responses. We bring the blanket to the person. We don't necessarily do that 6 months or a year down the track or 10 years down the track. We don't do that for people with complex needs. For someone who is coming out of the justice system, there is this nothingness. So how do we promote what in actual essence can be such a crippler of the situation already? I'm in pain, someone else is in pain, I want a service, I don't know where to get it, and then if I do get it, might not be exactly what's going to respond to me or help me at that moment. So how do we work together, build the plane and fly it at the same time, as we've all confirmed it's really hard? I'd like to see more promotion at every level, which includes then the education component, that we develop skills and knowledge as a community, as workplaces, as individuals. It goes back to knowledge is power. We don't know what we don't know. And if we can be, as a grassroots community, compassionate and learn the skills of compassion, learn the skills of education, learn the skills of conversation, then we've got a bit of a step forward. And if we can't access services, that you and I can make a difference, which goes back to the model of peer support and the model of community coming together. So I'd like to see promotion on several levels. Through the community, through our services. Word of mouth is huge. That's a massive way of us developing networks. And I think that goes back to a really important point that Tramaine made earlier around networks. We are still grappling with having time to network with each other, to grow our referrals. We don't always know where to go to because we don't know what's out there ourselves in the different spaces that we work. And that's why events like this today and other opportunities for the sector to come together and even broaden the different sectors that actually all of us cross in whatever human health issue that we may find ourselves, to communicate, to say, look, I'm over here, this is my expertise, and I'm over there, and I bring this to the table. How do we then bring it all together is through knowledge and education and supporting one another, and also talking. Let's keep the communication doors open constantly.
That's great, thank you. You've raised so many important points in terms of the importance of connection and communicating, and I love your reflections there as well on the value of compassion. And I think, so many things could be changed if we took that more compassionate mindset in how we're treating one another and ourselves as well. Rahul, I'm going to go to you next. Can you tell us how walk-in centres can work for and support those people who've previously experienced trauma from within the mental health care system?
Yeah, look, interesting question. I was struck when we were discussing this about an experience we had. We have, as we've kind of gone to design Transforming Trauma Victoria, we have a stream of activity that's been First Nations led around by VACA and VACCHO. And we were at a forum where someone spoke very eloquently about the impact of both systematic racism and also intergenerational trauma around his lived experience and his experience working in that sector as well. And he kind of boiled it down quite simply that, you basically, it's not enough to not be racist, you kind of need to be the opposite of that. It's this kind of restorative idea. And I think it's similar is true for those who've been harmed by the system, that you do need to kind of almost overshoot. We hope that being just trauma-informed, or I shouldn't say just trauma-informed, but trauma-informed will be sufficient one day. But I think given how live this issue kind of remains at the moment as an experience for people, it's still kind of important to do that. And I suppose that sits on a bit of a spectrum from the very simple things in terms of, does your consumer receive a phone call from a private number, or is it, can they actually return a call? Is there a message? Are there mechanisms to support that type of kind of friendly contact? versus, and then being all the way through to, knowing how to therapeutically intervene to support someone recover.
That's great, thank you. I love that concept of overshooting. I think that can apply to so many parts of the mental health system, but also our lives. So the first question we've got for our panellists is, have you been able to establish a clinical framework that sets expectations and standards for what treatments are provided and how clinical innovation is adopted? So Tramaine, did you want to reflect on that one from your US experience?
Sure, absolutely. I think that there's a number of approaches that we've taken in the US, one of which is the CCBHC framework itself. It is a framework. It is a way of identifying what are those clinical outcomes that are necessary. There's several components that go into that, and in each one, there's things like making sure that access is a priority, making sure that from a community perspective, how are you collaborating with individuals in the community? So not a set framework, but use of evidence-based practices is part of that framework itself, right? And we know that just like we are all very unique, every organization is unique, every community is unique, and which evidence-based practices are going to work for that particular population. The fact that you're using those evidence-based practices is where the focus is, and the need to establish them. Chuck talked earlier about this gap in the high mortality rates when it comes to individuals who are experiencing mental health challenges. There's also a significant gap from a concept, if you will, to practice of evidence-based practices being developed and then them becoming practice-based evidence in the community as they're implemented. And so what we hope to see CCBHCs do is kind of shorten that gap, make sure that evidence-based practices are being implemented more quickly because the resources are there to kind of support that implementation. I'll also say that it's important to think about practice and treatment across a spectrum. So if we think about prevention and early intervention, that's really, really significant and important to have happen in addition to the treatment that's happening. We've seen several CCBHCs, for instance, use things like mental health first aid to kind of bring that community engagement component of their work so that they're not only working with the individuals, but also working among the community to really bring about change across the ecosystem.
That's great, thank you. And Karen, I was wondering if you had any reflections from Nimai's experience, particularly in your reflection earlier about it being a 50-50 clinical and non-clinical workforce. Do you have any views on the clinical frameworks that are used by Nimai in your centre?
Yeah, so a bit similar to what you were just saying, of course, evidence-based practice, and then how do you roll that out into the practice, the evidence, and then how do you embed it? I think we've talked a little bit today about that. That's actually quite a big piece in itself, embedding it into the practice and getting the staff comfortable with where that sits, how that works. Apart from, of course, all of the other, standards we meet through accreditation and everything, which is about all that access and equity stuff, and having strong clinical governance across it as well to ensure there's checks and balances in place. But yeah, it's a new space. It's exciting because it's a new space. Yep.
Absolutely, and that closing the gap between kind of when the evidence is developed and then ensuring that's implemented in practice is a really important one, along with using the real-world implementation as a way to gather the evidence. So we might move to our next question, and I love the highlighting. It makes it so much easier. Thank you. So, for Karen, what has been Nimai's experience in rolling out Medicare mental health centres, and what are the biggest barriers you've encountered?
Okay, so as I mentioned before, so I won't go over it again, was recruitment and retention of staff in a new model. So even trying to get a clinical workforce, so we're competing against health for a start, so we can't pay the same wages that health pay. So we really want people that want to come and work in community, but then a lot of people don't actually have that experience. They've come from a clinical setting, which is quite different and has different structures to working in community. So there's been a big learning curve in that. I think we've done a lot of training and support for staff around making staff feel safe working in a community setting as opposed to a clinical setting where they might have a GP next door they can reach out to, that sort of stuff. So that's been one of the barriers. I think also I'm going to be tactful, but, trying to build those relationships, I think, across the ecosystem around things like with police, with the local hospital districts, I think they might be called here, was tricky as well, because it was not been done before. It was all new, and so there was some resistance, and that took actually quite a lot of work to kind of break down those barriers, to have them understand that actually this is safe and this will prevent people, or some people, going to the emergency department.
That's great to hear the strength of those partnerships in delivering the service model.
It took time, as Chuck said, it took lots of time.
Okay, we might move to the next question. And Tramaine, I think this one's directed towards you. So has there been any indication of a positive impact on early mortality from co-occurring physical health issues as a result of the holistic approach in the US?
How much time do we have to answer this question? Ooh, it's a big one. Well, I think the way that I would approach answering this question, I mean, CCBHCs as a concept is fairly, the road to get here was long. It's a fairly new implementation, right? So if we think about it from that perspective. The other way that I'll answer that is when we think about physical health, we also got to think about all the social determinants of health. And so one of the things that we've seen is that there's so many strategies that CCBHCs are using to really address the social determinants of health across a wide spectrum. We've seen that about 81% of CCBHC has increased screening as it relates to unmet health needs to really understand what is the impact that's there. We also have seen that those that are historically underrepresented or unrepresented to the tune of about 75% of an increase in CCBHCs being able to really get that data and understand the data. In order to understand impact, we have to have the data available, and that's at the heart of this model, is really understanding how and what should we be collecting, and then having that shared opportunity to understand, okay, from one organization to the next, are we counting the same things? Are we looking at them in the same ways? And how can we do comparison as a result? So I will say, in summary, that it is emerging, absolutely, the outlook and the opportunity to understand. I will also say that what we're seeing as an early indicator is that we're counting the right things in the right ways so we can see the good outcomes.
That's such an important first step in actually being able to assess some of those longer term trends, is firstly identifying what do we need to count and how can we do that consistently. Yeah. We might move to the next question, and Ingrid, I might pass to you for this one first of all. What are the most effective low cost but likely high complexity reform that governments could pursue in times of financial constraint?
Thank you. Now I'm going to take a totally different tangent on the response to this. I would love to see a government be brave enough to say, I don't know the answer, or I can't give you the answer to this question, as opposed to buck passing and not answering things and saying it's going to happen, or just dodge the question. How would it be if we had honest government, honest policymakers, honest researchers, all of us being really brave and courageous to either say, I don't know, and let's find a way to do it, rather than sort of, walking along the side. And I think that starts with our government. But also on the reverse of this is, I know in many families there are certain topics we don't want to talk about. There are certain topics we're afraid to talk about, and they're very uncomfortable. I know I often sit with my loved ones around a table and want to hit on a topic, and I'll get shot down because it's uncomfortable. And then when I push just a little bit, no, don't go there, I don't want to talk about it. And yet by not talking about it, by not being uncomfortable at that table, we're actually constantly doing the same thing that we want our governments to do that are not doing, which is having honest and brave conversations with each and every one of us. How refreshing would it be if someone got up, whether it was a politician, whether it was any one of us in our workplaces or our communities, to say, this is complex, let's sit together and work it out together, because no one of us has the answer, and nor should we expect one person to have the answer. And so we've talked about this networking and this building of relationships, which I think is key to a lot of these different questions. Actually, I think it is fundamental to these questions. How as we as human beings can sit together in the mud, feel uncomfortable, lean into the discomfort, and then work through it together, using and maximising our strengths and actually putting our vulnerabilities and our weaknesses and areas for development in a context where we can say, how do we learn? How do we grow? And I think there are really rich opportunities for us to develop deeper relationships, deeper ways of working, and then therefore deeper ways of giving to the community that we serve.
Thank you, Ingrid. I think there's so many important points that you raised there, but I love that sense of just acknowledging that we need to be uncomfortable to get progress and change, and that's an inherent part of change. And actually, if we're not feeling uncomfortable, it's probably a sign that we're not changing hard enough. And I think that applies kind of in our relationships, but then also in policy design and implementation as well. Rahul, I might go to you for the next question, if that's okay. This one is, how do we support people to access therapy in regional and remote areas, particularly if their presentation makes them feel uncomfortable answering a phone or text?
Sure, great question. I think look, it's probably a blend of the twin principles around flexibility and practice confidence. I think flexibility in terms of process and in how you kind of reach out to people, what options you give them in kind of starting to dip their toe in and then perhaps entering into a more kind of formal therapeutic kind of encounter. But the practice confidence piece is equally important. You know, if you have a workforce that, you know, not just kind of read or had the training in, but actually witnessed people going from, you know, fetal position in session 1 to, you know, being able to have a laugh in, you know, session 10 or what have you, that gives that real kind of practice confidence to be persistent and apply that flexibility and kind of bringing those services to people. And of course, telehealth and the rise of telehealth has really helped that. But it's also no substitute. So as much as people can kind of have a blend of experiences of kind of that face-to-face and telehealth and meeting people where they are, I think that's the main recipe.
That's great to hear. And Karen, would you like to share some of your reflections on how to improve
Thank
support?
you. I just want to give an example, actually, of where this has worked, and it's worked quite well. So you probably understand Australia's a very big country. So we, you know, lots of our country is rural and remote and regional. And so North Queensland there's a lot of remote and regional areas up there. There was a model, and it was through the Step Care Initiative, so people in the room would probably know what the Step Care Initiative was. And it was a great model, and it was a access point, I guess, or a pathway through to psychological therapies across the whole of North Queensland. So that included the more areas like Cairns and Townsville, but it also included all of the much more remote regional areas. So we worked really hard on building relationships, back to relationships, with those local communities. We weren't going to be all, end all. We weren't going to go into communities we knew nothing about. We built really strong relationships and supported training for psychologists in those regional areas. And then the pathway through meant we had a very close relationship with them, and we were the referral point through for people. So we did about 10,000 referrals a year, and it worked really, really well. And it was about having those services that were already there, upskilling them for what they needed, providing them the training that they needed, and paying for that for them, and then building the relationship for the pathway. So it worked really well.
That's great to hear that really practical example of where it can work well. Thank you. I love this next question. What initiatives could the sector partner on to take the lead in effective reform where government has or cannot? Did anyone in particular want to jump in for this one?
Okay. Look, I think as we go through the reform journey, I think there's always a tension between the formal and the informal, and the abstract versus the very human kind of messiness that health services are. And I think government is often necessarily kind of has to follow those kind of formal processes. But I think this, as a sector, we know the kind of real world and the lives of those that we engage with and help support. And so it's a lot of those kind of informal relationships. I know a lot of the people in the room are those that whose doors I've knocked on multiple times to say, does this work for you? What do you think of this? And, you know, does this meet the needs of your community, and can I talk to your kind of frontline workers or consumers about X or Y idea? So it's that piece that I think the government should fund, but are not necessarily in a position to kind of get into the weeds of. So I think that'd be my.
That's great, thank you. Ingrid?
I think we've got to remember that we work in workplaces. We also have a huge workforce in corporate Australia, and I think we can't underestimate that they also have a role to play in everyone's health and wellbeing. We know that there's occupational health and safety legislation in place now, that they have a duty of care. We have a duty of care to create environments that are safe psychologically as well as physically. But here's an initiative or initiatives that we could tap into, that corporate Australia could actually come to the party and help us to promote health, mental health, wellbeing, trauma, all the range of health and human conditions that we see in our workplaces every single day. So perhaps there's a way that we can bring corporate Australia to our tables, build relationships with them. I know that there is a fear within corporate Australia about what's the liability here if we go down this path. There is still that stigma in our workplaces. We're still not ready to employ people with a mental health issue. I know that I'd be really reluctant, and I do. I actually mentor a lot of people who are going for jobs to not disclose their mental health vulnerabilities, because there is still that, this is going to be hard going, this is going to be, they're unreliable. We hear the them words are still really prominent. So how can we help engage beyond government funding that is out there? We just have to find other innovative approaches, and I think today we've got an opportunity to start doing that, not only with mental health first aid education, but a whole range of different education programs. And forgive me, Gus and team, if I'm promoting a whole range of different challenges, but it goes back to context. And we have the opportunity, we've got education programs, and what a wonderful way to bring it together, because no one size fits all. And being open and honest and developing relationships in different contexts may well be the way to help start furthering initiatives around how we create mental health care in a promotion, prevention and early intervention approach.
That's great. Thank you so much, Ingrid. So I think we've got time for one last question. So to wrap up the panel, the question is, how do you support skill mix consisting of clinicians and peer and lived experience workforces working together? Anyone in particular want to jump in?
I'm happy to go with that.
Yep. Yeah, go for it, Ingrid.
Just touching back on the education piece, I think one opportunity is to bring clinicians and consumers and carers to the same table and doing education together to actually exchange learnings and wisdom and understand, hang on, we each come from a different perspective, and maybe in doing that we also address this sense of power and power imbalances that we often feel in whatever role or whatever hat we wear, that can actually enable us to find some common ground. That education is about sharing and about developing new thinking and new knowledge. And how do we create that new knowledge is by talking to each other, which goes back to where I started from around communication. It's through talking, sitting in the mud together in whatever mud patch that might be that we find ourselves. And I think by sitting down, having open, honest, uncomfortable conversations between the different domains that we come, and as I know, I'm sure many of us know who Brené Brown is, being vulnerable actually is creative. It builds strength and it builds compassion. If we can do that in a mixed workforce, I think the results will speak for themselves to those that actually need our support.
They are speaking for themselves already.
Yeah.
Through the centres, certainly what we're seeing and the data's telling us that is actually working. It's hitting the mark, and people are feeling really comfortable and having their needs met by having different disciplines in the one place. Can I just add, it is tricky, and I totally agree with you that you need to have those hard conversations and get people around the table. You also need to support people to balance that power, which you mentioned, and that's what we see a lot of. So you put clinicians in the room, and I don't think there's any intention if there's clinicians here, but can sometimes overpower the voice of the lived experience staff that are sitting in the room, or the lived experience voice feels a bit shut down. And so, we work with our lived experience workforce to raise that voice, to be equal partners. There's none of this or this, but they're actually equal in the conversation. Yeah.
Great. Rahul, did you want to comment as well?
I was just going to jump in just as well as it's back to that tension a little bit around the formal and informal. I think there's a host of kind of policies and structural things around kind of co-leadership and co-production, and Ingrid's helped us a bit with that thinking as well, that can support that. But important also not to forget the informal opportunities for people to just see each other as humans. And I think both of those are really important.
That's great, thank you. And Tramaine, did you want to round us out for this question?
Sure. I will say that that's at the heart of what CCBHCs are trying to do and trying to achieve, and I'm hopeful that while we couldn't get too much into it here, there are we have these great on-demand videos on our website that really delve into what this looks like and what it looks like to have an integrated care model, bring voice, choice, power into the conversation, in addition to making sure that there's opportunity for that empowerment of individuals with that lived experience to be part of the solution, but also to drive solution. There's this phrase that I'm sure that you use here, that we use the world over, of nothing about us without us. And I think that is true of whatever our experiences are, no matter what country we're in, that we all have the ability to make progress if we do it together.
That's such a nice comment to end on. And I think for me, those answers just now, it really summarised one of the earlier questions that we had in terms of what are the opportunities where the sector can lead reform that could be better done by the sector rather than government. And I think kind of shifting power balance and learning from one another and thinking about the cultural changes that we need across our mental health system. I mean, governments can't lead that work. It absolutely needs to be done from a bottom-up, sector-led approach. So there's so much opportunity ahead of us. So please join me in thanking our wonderful panellists for sharing their insights with us today. So I would just like to extend my thanks again to the Mental Health First Aid International team for co-hosting this event with us at Mental Health Australia. So in particular, thank you to Gus, Christian and the broader team who made today possible. Thank you again to our panellists for your important work and your willingness to share your insights with us. And of course, a very warm thank you to our keynote speaker, Chuck. It was so wonderful to hear your insights about what's working well in the US and what we can take from that in informing our Australian experience. So please join me again in thanking all of our speakers for today. Now, I think we have about 30 minutes left if you'd like to